Hello, everyone, and welcome to the 50th session of Virtual Shadowing. If you are new to our Virtual Shadowing program, I want to officially welcome you, and I'm so glad that you could tune in with us today. Today's session is a PA Spotlight with Leanna, who is a certified OBGYN PA. As always, if you have any questions or concerns, feel free to reach out to our email at virtualshadowing@gmail.com or DM us on Instagram, and our handle is located below. As always, these sessions are recorded on our YouTube channel, Pre-Health Virtual Shadowing. Next slide, please. This virtual shadowing session is brought to you by our fabulous working group, which consists of Reagan, Rachel, and Ruth, Cheyenne, Miriam, Taylor, Rohit, Elena, myself, and Ali. And then also our physicians, Dr. Fowler, Dr. Moschetti, Dr. Salazar, and Dr. Reno. Next slide, please. So we have some awesome sessions coming up. We have a family medicine next week, a medical student panel, hospitalist medicine, and a nurse practitioner spotlight in primary care. And you can always join us on Zoom for each of these sessions or YouTube Live at 7 p.m. Central Standard Time. And make sure to be added to our emailing list for more details on those. Next slide. And as always, we'll have 2 Q&A sessions. So if you have any questions throughout this presentation, just make sure to drop it in the chat box and our virtual shadowing team will get to it as soon as we can. Next slide. And finally, we have the wonderful Liana, who's a PA and an OBGYN. She uses her social media platform as a wonderful outlet for women to answer questions, and I'm so excited for her to be here today. So without further ado, I'll pass it on to Liana.
Hey, Leanna, let me just chime in for 2 seconds, and then sure. We will turn all 400 of our closest friends over to you for looking forward very much to your remarks this evening. Welcome, everybody. Good to have you. This is the 50th lecture, if you can believe it. All the lectures are online. We're coming up on a year of doing this, and we're examining about whether we'll go forward. We'd like to hear from you in chat. If you want us to keep going, we'll do that. We're prepared to do it, but we want to make sure that the enthusiasm is there for, look at all the yeses popping into chat. Thank you for that. Because we have a lot of good ideas. For example, I had lunch this week with one of them. As many of you know, I'm on the admissions committee at UT Southwestern Medical School, and I had lunch with one of my fellow members of the committee this week. And we thought that what might be a fun session for you all is to do some practice interviewing as one of the virtual shadowing sessions and actually do real interviews. So we're thinking about doing that. It would be probably the first week of July, which would take us into the second year of doing this. So we all promised you at the beginning that if you keep coming back, we're going to be here. We're now at over 250,000 views of our lectures. Can you believe it? We've given out over 200,000 attendance certificates, exam certificates. So clearly there's a need, and we want to be here for you. So just want to welcome you, and I'm so glad that you could come. And tonight we are so delighted to have just a marvelous figure who is so sweet and so smart. Liana, I'm so glad you could come tonight. On the behalf of nearly 500 of our closest friends from around the world, we just want to welcome you and just invite you to a warm, relaxed, fun session. So why don't you take it away?
Thank you. And just a very big thank you to Dr. Fowler and the committee for allowing me to be here today and sort of share my personal experience, my path to becoming a PA, as well as what I do every day. And just for providing a very big platform for all of the pre-health professionals around the world who are unable to find, in-person shadow opportunities at this time. So I just think that's fantastic, and I love it. Moving forward, so my name is Leanna, for anyone who doesn't know, and I am an OBGYN PA based out of the Metro Detroit area in Michigan. Throughout these slides, I'll talk a little bit just about myself, as well as, my background, what brought me into becoming a PA and why I chose women's health. So like Dr. Fowler was saying, really relaxed conversation. and open to all questions. And I look forward to all of you learning a little bit more about me. So first slide, I'm currently 25 years old. I grew up in the Downriver area in Michigan, but I currently live in Novi. Now, one thing I always love telling people, especially people who are freshmen in college or sophomores who sort of had a background that wasn't very science or math based. And in high school, I never really cared for the sciences. I was good at it, but I never pictured myself necessarily in medicine. I was always stronger in writing and English, and I loved arts. The APs I took were photography and psychology. So I avoided bio and chemistry as much as I could. When I was approaching to being a senior in high school, I believe the summer of when I was a junior, I had actually shadowed an OBGYN PA. Just out of coincidence, because my father is actually a gynecologist, and he had talked about being a PA to me, and to see if it was something I was interested in, and I just never heard of it at the time. So I had shadowed her, and I came to realize that, you don't necessarily have to become a doctor to be able to care and treat your own patients. You sort of become, a vital component to this medical team and sort of provide the best quality care with everyone within that team. So I quickly realized that I wanted to be a PA when I was a senior. And so I had applied to a fast track program at a private university in Michigan, which was the 5-year PA program. I believe they have quite a few of them in the country. I'm not necessarily familiar with how many other universities have the 5-year option for those who are seniors in high school. And so I ended up getting accepted into that. Now, one thing I'm very transparent about with people who know me is how hard undergrad was for me as far as my first semester, and how my GPA wasn't always the best. And we will get into that, and how you sort of overcome those things and make them more of as a blessing in a way during your interview process. So these were just my stats for anyone who is in high school or was interested in a 5-year PA program for someone they may know. For our curriculum, you just needed a minimum of an ACT of a 26, and then a GPA of a 3.5 or higher. One thing I like to show for my undergrad degree, we had 2 options because, our curriculum was pretty much set for us. We didn't really have much leeway as to going outside of it, but we could either be bio or chem majors. So I chose biology. My GPA by the time I graduated in the 3 years was a 3.7. My GRE was a 305, and my patient care hours, we needed 1,000 as a minimum to stay within the program. So I had got my CNA certification, but I actually worked at a women's health clinic.
Now, Leanna, what did you say? What is the 1,000 hours? Patient care, what?
Patient care experience. So working as like a CNA, a medical assistant, anything with direct patient contact.
So it says your minimum. What do you mean that was your minimum?
So to save our spot essentially in the PA program, in the master's program, we had to hit a minimum of 1,000 hours while being in school. If we were to get less than that, then our spot was no longer saved and we weren't guaranteed that spot in the master's program.
How did you find the 1,000 hours? I mean, you had to go find it yourself, or did they schedule that for you somehow?
No, we had to find it ourselves. So right off the bat, I had picked a CNA certification because we could get it in 2 weeks. There was it was much faster than a medical assistant or like an EMT. So I had done that. And then, you just accumulate over time, do that while going to school and working. So they pushed it from the very beginning.
No kidding. So what has happened to that kind of experience during the COVID era?
So I actually believe, this was back in 2015 when I was a freshman. So I was out by the time COVID kind of started. I graduated in 19. But for what they're doing with the 5 years now, I don't know if they're making them meet that minimum anymore, or what they're expecting. I'm assuming the marker of 1,000 hours is just because for a lot of the PA programs in the Metro Detroit area, competitive is considered over 1,000. That's sort of what the pre-PAs are trying to hit before applying for their cycle. just from what I've been seeing. Now, one thing I bolded was my GPA, which was the 3.7. And the reason I bold it is because GPAs can be very deceiving. You know, you can't really tell or assume, you know, a person's struggle by looking at their final GPAs. So one thing I always love to stress to anyone in undergrad is I just call it the GPA deception. So my first semester of undergrad, these were my grades. You know, I was taking 5 courses, I think, my first semester. Biolab, I got a C. Chemistry, I got a D. And then pre-calc, I got a C. And these are the grades I was approaching the end of the semester with. Now, I was someone that kept going to those after class activities, trying to boost it. And so by the end of all that, my pre-calc professor, honestly, I think just felt really bad that it just wasn't clicking. So he gave me the B-. And then my biology lab stayed a C. And then my chemistry, the professor knew I was actually going to retake that course. So she gave me a C instead of a D. Needless to say, the 5-year PA program committee put me on academic probation and basically said, because I believe my GPA that first semester was a 2.8, I needed a 3.5 to stay within the program. And they only give you a semester to do that. So what I ended up doing was I took 7 classes the following semester. I repeated Gen Chem 1 so that it would swap out my C to an A. So I retook chemistry and got the A. And what I ended up doing was kind of working around the system. I took 7 courses instead of the 5 that they had scheduled for us. And then what I did was divide up the other semesters by taking summer courses as well, so that my GPA would just increase at a faster rate. One thing I always say, though, is just because you have a bad semester, it doesn't mean you have to beat yourself down about it, because at the end of the day, what I did was I had used that bad semester as a representation of how hard I work and how I don't give up when faced in, you know, low points, if you will. So I almost flaunted it in a way during the PA interview process. So really, you just take one of those things, and as long as you show hard work and, you know, you show improvement, you can actually end up using it to your advantage. Let's see.
All right. So how in God's name did you go from a D to a, what, did you make an A from a D? What did, you took the D over, right?
I got a D in chemistry, but I had explained to the professor that she had asked me, are you retaking it next semester? Because if you are, then I'll at least just give you a C. So she gave me a C. So my final grade was a C. And then the second semester, I was taking Gen Chem. No, I don't even think I could do that. I was thinking if I took Chem Lab 2 because I passed Chem Lab 1. But I had done a retake of chemistry, general chem, and I got an A in it. So at my particular school, they will swap the grade, so which is nice. So it's as if it never existed. And that's really the only way I was able to stay in the program, is because of that swap system.
Yeah, but how in God's name did you go from a D to an A? Did you have an electroshock therapy of your brain, or did you get a brain transplant, or what did you do to change, to turn around like that?
You know, I think my first semester, you know, I could have made a lot of reasons as to why my grades were the way they were. You know, maybe I wasn't studying as much as I could, or I could have said, you know, I had family stuff going on, which all those things are true. But at the end of the day, you know, you're battling with yourself. You know, I don't really like to make excuses for why things were the way they were. And I went to the committee and I had said, you know, can I get another semester? Like, I don't know if I can boost it in one. And, you know, they said no. And so there is only one solution. I mean, you had to get the A.
Well, if I may interject one more time, we are not in a hurry this evening. I hope you don't mind.
Not at all.
I just finished a really important book called Make It Stick, which is about adult learning. Yeah. And it is a very interesting thing. And it has to do with not only immediate stuff, you know, where you highlight a book, you can remember it for 5 minutes and then it just goes right out of your mind, or you you bone up for a test, take the test, and immediately forget everything that you knew versus long-term recall. And that is why I was asking the question about how you were able to turn around conceptually as well as memory-wise. How in the world? Or was it because you'd seen the material once and now you saw it again, so it was more familiar, possibly?
Yeah, I think that's what it was. You know, it was one of those things where I felt like my first round, it's like I knew things, but not to a complex level. Like it was very superficial understanding, so that during the exams, I wasn't able to take what I learned and figure out complex situations with it. It was more of just the very like superficial part. So retaking chemistry, I already knew that the superficial part, if you will. It was understanding how to use that into more complex situations, which I then had time to do because it was repetitive. I've seen the material before. And I ended up honestly just spending more time with that particular professor, going to a lot of after hours activities, just because I knew my weak point was chemistry.
Did he write one of your letters, or your reference letters?
They didn't actually. My Orgo professor did.
All right, keep going.
All right. So, for those who don't know, so for graduate school, what that looks like, I was, at Detroit Mercy, they offer, the 5-year. They also offer for applicants after you finish your undergrad, a 3-year program part-time or a 2-year. And so for me, it was the 2 years. So year one was what we call didactic year. So it's basically book work. Every month we're covering a different specialty and area, and at the same time taking anatomy, physiology, pharmacology. And with me, I actually found the master's program to be easier than undergrad, only because at this point I understood how to study and stay organized and just sort of stay on top of things. And so for me, I just used a planner pretty religiously. That's just how my mind worked, as once it was in there, it had to be done. And always, to work ahead, especially in classes like anatomy. It's always better to just study and study ahead, because the material will pile up very quickly. So consistency is key. And I always say it's stressful, but definitely not impossible. I hear a lot of people who question, am I able to balance like a life with school? And coming from someone who struggled in undergrad, I was, completely capable of having, a social life as well as balancing that, studying and everything like that. So as long as you're consistently working ahead, you won't feel too overwhelmed. And then year two is clinical year. So every month you're rotating in a different specialty. And after each of those rotations, you take an end of rotation exam based off of that specialty that you were just in. And then as you get closer to when you graduate, you're going to start also preparing for the PANCE. I started doing that on my last rotation. And I think a big thing that I regret is being, a bit more, I consider myself more of an introvert. So I was pretty passive on a lot of my rotations. I was more of like a watcher and observer, not so much of a go-getter. So one thing I always tell students is please make those connections and ask questions and just be, the right hand man or lady for, all members of the team wherever you work, whether it's in an office setting like outpatient, show respect to the front desk, the medical assistants, to the nurses, to other mid-levels, NPs, PAs, and the physicians. Don't just focus your attention and your time on whoever you're rotating with at that particular moment, because at the end of the day, these could be future employment opportunities. And a lot of people get job opportunities based off of where they rotated. And these are also the same people that will provide you with letters of recommendation if you really do impress them. So really it's about the willingness to learn and the respect for all people in the environments you're put in.
It's interesting, Leanna, that gradually increasing number of questions for medical school, and I would imagine for PA school, having to do with cultural sensitivity. Mm-hmm. This is most definitely the woke area, and so I see additional questions. For example, for essays, for example, there may be a question for an essay for application, right? That is, what is an issue of cultural sensitivity that you've seen come up, and explain how that made you feel, or things like that.
Mm-hmm. So things, especially working in women's health. So one of the interesting thing is I came from a very, traditional Arab household, being a woman, my own knowledge of women's health was limited just from the cultural side of things. And when I first started working as a PA in women's health, it just so happened to be working primarily in an area of a lot of Arab American women, a lot of Muslim American women who, had the situations I was exposed to were things I never thought existed, at least in America. And this is coming, from an Arab American who's raised in a more traditional aspect. But, things regarding, just understanding that some women culturally, when it comes to themselves and their own bodies, there's a huge misunderstanding or lack of knowledge of and taboo when it comes to their own health. So when they see a provider, that provider is sort of their only go-to and their only source of information that they have regarding themselves, which was a huge reason and love of why I went into women's health, is because there's no one else to teach these girls, whether they're younger or older. It doesn't matter how old they are. There's no one to advocate for them. There's no one to teach them. So I have girls coming to me and, they have like discharge and they're freaking out because they've never been sexually active, and there's no one to tell them that that can be normal. So culturally, as far as like, the side that I'm more exposed to with the Arab Americans and the Muslim Americans, when it comes to women's health, there's no one there to teach them, no one there to advocate for them. And so a big reason why I had, I'm not a social media person. The only platform I have is my educational platform, where essentially I'm teaching girls women's health topics that they're not going to be able to be exposed to or be able to be taught, especially in the educational system. I was never taught any of these things, just in school.
Well, Liana, flip side of that, as I told you, I've been around a long, long time, and I have seen women die of cervical cancer. And it's horrible, as you know. It's terrible. Yeah. It's interesting that in the suburbs of Atlanta, where I came from for the first 20 years, you almost never saw it. And then I came here to Dallas, Texas, and we see it all the time.
Yeah.
And so we know that is a form of cancer that is essentially preventable through the HPV papillomavirus wart virus vaccine. And yet we have these bizarre cultural things that says, no, we're not going to give you the the HPV vaccine, because then you might start going out and having sex. And you go, really? You're not going to let the person be prevented from getting cervical cancer because of a fear that they may think, why don't you try sex education and tell them also about HIV and herpes and gonorrhea and chlamydia and pick another disease? It's strange.
It's amazing. It really is. I can't say I blame them, because in a sense, I was raised around people who, think in that way. And so I can't hate them for it. I can't look down on them, because from a cultural sense, I get it. But it's really just the lack of education. And you're absolutely right. Especially a lot of Arab Americans, they will not give the Gardasil. They'll do all the other vaccines, but the Gardasil, they'll typically wait on until she gets married. But what's sad is that parents assume their kids aren't sexually active when they are. And then in that sense, their quality of care is automatically diminished, because there's that disconnect because of the whole cultural stigma and their reputation. And so then you have these younger, individuals who are sexually active, whose parents don't know, and they don't want to tell anybody because of the stigma around it. And they won't even tell a provider, because somehow that'll get back to the family. And so, there are situations, truthfully, where I've had young girls come in And they'll come in with a parent, but I typically try to separate them. And just take like the HPI with the parent not there, and then have the parent come in with, during the actual exam. And so I'll always explain, like, if you are, there's a swab I can do where I can add on, gonorrhea, chlamydia, trick, but it also tests for BV and, yeast. These are things that aren't sexually transmitted. So the swab, if you had to tell your parents, the swab is testing for vaginitis, because it is. But consequently, I'm also protecting and making sure that you don't have an STD. So the goal is to really, I think, my hope is that other providers who aren't Arab American kind of understand that culturally it can become so overpowering for that community, where really you just sort of, it's a big complex topic. There are a lot of issues associated with it. It's the fact that I feel like a lot of, from the patient side, they're not comfortable telling the provider. And then from the provider side, we just have to provide ways to be able to protect them and provide the education that they need in a way that it won't scare them.
Absolutely. Well,
Yeah.
I know you need to move on, but I'll conclude with a couple of sobering thoughts. Half of Americans have a wart virus living in their genitalia. It's everywhere.
Yeah.
One fourth of Americans have herpes on their genitalia. 75% of Americans have herpes on their mouth, even though most of it is latent infection.
Yep.
These conditions are everywhere, and that's why education early with realistic people who really care can make a difference.
Absolutely.
Well, I didn't mean to get you off. These are both obviously very interesting subjects, and
yeah, it's like a whole other conversation. I'm glad you asked, though, because it really gets me going, and it's these thoughts that I've always had in my mind, but separate conversation.
Yes, ma'am. Oh, great stuff. Please keep going.
All right. Okay, so why did I pick women's health? Something I'd like to point out is actually when I was in PA school, I thought I wanted pediatrics, specifically peds oncology. But my first rotation I did during my clinical year was pediatrics. And I realized quickly, I think I'll pass. I don't think kids are for me. And I think one of the big reasons was because I really value, the conversational component to patient care. I love for the patients to sort of be their own advocates. And a lot of times in things like pediatrics, you're, primarily working with the parents and not so much the child, obviously. So for women's health, I obviously love taking care of women. I see, 12 and older at my clinic. One thing I really loved is, I find that my personality best fits with focusing on one particular area of medicine and sort of mastering it rather than kind of know a little bit about a lot. In women's health, you can work strictly OB, meaning only pregnant patients. You could work strictly GYN. So you see, all the gynecological issues aside from pregnant patients or a combination of both. I personally see both, but I only work outpatient. I don't work inpatient. For those who don't know, inpatient means you work in a hospital-based setting, and outpatient means you work more in an office setting. There's a very big educational component to women's health. I had gone through a phase where I thought I may have wanted to do like part-time teaching and then part-time working. But I find that working in women's health, it's a lot of teaching and a lot of patience. I don't like to do anything, when a patient comes in, I don't like to just say what the answer is and call it a day. I want to explain what I'm doing and why I'm doing it so that they can start to become their own advocates and learn. And some care and some don't, but I feel like I'm not doing my job if I'm not explaining, what a pap test is. So many women come in for their pap smears and I'm like, do you know what I'm doing? And they're just like, swabbing me, STD check, they have no idea. So for a lot of these women, I have to go through the whole anatomy, explain what the cervix is. And I've caught women who say yes, they know what a pap is, but for example, they're like 19, so they haven't had a pap and they say they did, and it's interesting. And a big thing for me is becoming their advocate, like I said, especially for the minorities. And then for those who are interested, there can be a surgical and procedural component to women's health. There's a lot of in-office procedures as well as inpatient surgeries that PAs would be able to first assist in if they're willing to. And for me, it was important to have a work-life balance. So, I like knowing my schedule. I'm just a Monday through Thursday currently, an 8:30 to a 4:30 for the most part. And I just like being able to go to work and know when I'm going to leave work and nothing really crazy is happening in between.
Hey, there's just popped in chat. Someone says, I'm kind of scared of getting a pap smear, but hopefully it won't be too bad.
A lot of people, I don't know where these stories are coming from, but, my big thing is just find someone you're comfortable with. Whenever it's a women's health issue, you just sort of have to find that provider that you're able to relate to and can kind of put you at ease. A pap test, unless you have some sort of underlying medical condition that would make it more painful than what it should be, I always say, as long as you can tolerate a speculum going in, you will tolerate a pap smear. It's not bad at all. I've had plenty of patients get it and they're like, is that it? And I'm like, that's it. So, yeah, don't always listen to the bad stuff. There's so many of it, IUDs, girls get so scared with the stories they're told. And not that I think that what, the other person went through is not true. I think it really just depends on the provider, to be completely honest with you. Okay. So as far as, chief complaints coming in, I see a lot of annual exams, especially first-time pap smears. A lot of my patients are, the late teens to the 20-year-olds. From what I've been seeing, a lot of people coming in for painful periods, irregular periods, pelvic pain, having history of cysts. People come in for their STD checks, birth control counseling. I see my prenatal care patients, so my pregnant patients, the routine visits, PCOS, endometriosis, and vaginitis. And then to the right are just, surgeries or in-office procedures that mid-levels are able to do. I personally don't deliver babies. I don't do anything hospital-based, so DNCs, ablations. I assisted in those when I was on my rotations, but I don't work at all in the hospital. So this is kind of like an image of what one of my days look like. So that would be my schedule on the left. And then on the right, you can see with the ages can be anywhere from, teenagers. Like I said, the youngest patient I've seen is 12. And then, up to 70s, 80s, 90s. I find that most of my patient population is on the younger side, 20s, 30s, teenagers, whereas the doctor in our practice tends to see more of the older population. And I think that also goes hand in hand with the fact that 50 and above, they kind of look at me and they're like, I don't know if you're qualified to touch me, basically. Some are really sweet about it, but other ones are just like, I don't know about you. So that's one thing to look forward to when it comes to PAs, especially if you're a newer grad, is looking young and having that baby face. You're going to get a lot of different takeaways. Women are typically really nice about it, but like during rotations, I'd find that, over the bigger picture, some people just are like, I don't know about you.
So you don't have any gray hair yet, huh?
I do. They're just scattered. It's the stress and genetic, but I do have gray hair. I just hide it well. I'm an old soul. All right.
So why don't you deliver babies?
I'm going to be honest. It was never an interest of mine. It just never was. Like, I love seeing my pregnant patients, but I never had that passion or desire to want to deliver them. And in Michigan, I believe in some states, the PA could be the primary one delivering the mom, but over here, you would be first assisting. In the hospital that I'm associated with, they don't have a lot of PAs doing that role. We do have PAs on labor and delivery, but they're not, to my knowledge, part of the delivering process.
Do you do much counseling of women who are thinking about getting pregnant?
I do the preconception counseling, yes. You'd be surprised how many people don't come in for it. They just kind of bypass it. You give them their preconception counseling once they're pregnant.
Exactly.
Yeah.
One time back in the 70s, I was working in a big ER back in Georgia. And this 15-year-old young lady came to see me and she was in the exam room with her, gown on, because she was having some nausea and vomiting and some diarrhea. And I talked to her for a bit. And I need to point out, I was like 24 in those days. I was younger than you even. This green 30-year med student, right? And so anyway, I'm seeing the girl, and it just sounds like she's got gastroenteritis, vomiting and diarrhea. I said, well, this is probably just a virus. Why don't you lay down and let me look at your stomach? So she lay back, and I pulled up her gown, and here is this 9-month gravid uterus staring at me.
Oh my gosh.
And I said, you do know that you're pregnant, don't you? And she said, and I quote, I was afraid of that. And I said,
she was
when was your last period? And she said, October. It's July. And so, in fact, the cramps that she's having in her belly are labor. And I got to go out and tell her mother that she was about to be unknowingly a grandmother.
She was hoping that it would just go away. She was
hoping that it would. And I asked her, I said, when was your last period? She said July. October. And I said, well, what did you think happened? And she said about her period, I just thought they went away. And they sure did.
Those stories are true, I guess, when people just deliver and not know, Ugh.
I'll tell you another story real quick.
Please do.
I was in the ER one day, and I was sitting at the nurse's station having my cup of coffee just like this, and I was just about to sip it when, boom, the ER door opens, and this guy comes running in and says, come quick, my wife's about to have a baby. So we go out, and there's this little Dodge, little barely 4-seater car. And there in the passenger seat in the front is this young woman, great with child, screaming bloody murder, and the head is about to come out.
Oh my gosh.
So and she was a primate, first delivery.
Yeah.
But the head was already coming out, and she was screaming bloody murder. We could not move her. So I got them to bring the precip tray and to come out. This was in the ambulance loading dock. And so they brought the tools, and she's screaming bloody murder. And so I've got one leg over the back seat and one leg over the dash, and people are holding it.
Yeah.
And I'm having to inject her to do a episiotomy because she's the first time. And she's screaming. And this anesthesiologist comes up to me and goes, puts his face right here. He said, Ray, can I do anything to help? I said, yeah, get her to shut up. She keeps screaming, and I got the head coming out. And suddenly she stopped screaming. And I look up, and Dr. Chevy was his name. And he has his face down in her face, and he's saying, you're about to experience the wonderful miracle of childbirth. And we got that kid out, and he did okay. I'm sorry. Let's do some questions. I'm sorry. Too many stories.
So we have
Kiana, you're on.
Yes, so we have some awesome questions. So the first one is, how did you balance classes with 1,000 PCE hours?
I don't even know. So yeah, I can't even, for me, it was very strategic. Like I said, what I ended up doing after my first semester, and I realized, I don't know where my life is going. I ended up splitting, because keep in mind, our curriculum was set. And so what I did is, if I saw that one semester we had 5 classes, I would take 2 of them out and throw them in the summer. So I would take away some of the load and then work in those additional time slot and on those additional days. I also tried putting all my classes on the same days so that I had like an extended week. So like a Monday, Tuesday, Wednesday, and then a Thursday, Friday off. And time goes by so fast, but they accumulated over time.
Right. And the next one that I keep seeing is why PA and not doctor? And are there ever any instances of hesitancy because of your PA status and young appearance?
I feel like I'm in PA school getting interviewed. They always ask you, well, why this and not a doctor? And so my dad is a physician and God bless him. He wanted his kids in like finance or business, something different, something, to excite his mind. And we all sort of fell into medicine. And so, you know, initially, before even PA, I was actually thinking of being like a sonographer, an ultrasound tech. But I realized I wanted to be more involved in patient care and making their decisions and their plan. And for me, PA was brought up. And then, of course, the thought of being a doctor. And, honestly, what I wanted to do was I wanted to provide great care to my patients, have a say in their treatment plans. But for me, I was never necessarily seeking that ultimate leadership role. I love the relationship mid-levels have with their attending and supervising physicians. And for me, I that relationship was something I really looked forward to. I was never necessarily the one that wanted to be calling all the shots. I was more so wanting to be the vital middleman of the team. And at the same time having that autonomy in a way where I can take care of my own patients, but have that doctor when I need to on the more complex cases. And so having the ability to do that, and God bless you, Dr. Fowler, and not spend 8 years plus in additional schooling. For me, it was really more of that work-life balance. And honestly, a big thing for me was always a fear of picking the wrong specialty or getting bored in whatever specialty I chose to go into, for the rest of my life. And, I firmly believe that how happy you are working in your job is really how it's going to reflect your care on your patients. So the happiest version of yourself, for me, I didn't know if I could dedicate it to one thing. And so I wanted the ability to switch out when I could. Now, does that mean I never thought about going to med school while I was in PA school? I did. During my clinical year, I actually looked at my dad and I'm like, I'm thinking of doing a bridge program. I think they had one in Pennsylvania, PA to a DEO. And I'm like, I just feel like I don't know enough. I was rotating with med students and I'm like, God, they have so much more education than we do. And, I just have to remind myself it's a completely different profession and, you're going to feel dumb. And I mean, when you think about it, I've had 1 month of women's health education, 4 weeks rotating in OB-GYN, and now I'm expected to go out in the real world and just take care of patients. So I've had my doubts. I'm happy I did what I did, but that's not to say that I haven't thought about wanting to, go back to school and become a doctor. But I then ultimately realized that's not what you wanted. Remind yourself that just because you kind of feel like you don't know everything now, it just happens with time. And so for PAs, I think that's the difficult thing that they have to overcome. But the nice thing is they are coming out with more residency programs to sort of extend that education for PAs to make them not feel like they're kind of thrown out into the real world and they have no idea what's going on. So,
Hey, Leanna, let me jump on that.
Yeah.
I worked in Parkland ER along with Dr. Salazar, who's with me, and I'm sure Elaine does too. We work side by side with our PAs, and we expect the same applied scientific approach on all patients, all of us, to do the same thing. The era where I came from, there were hardly even computers, certainly nothing, of course, long before the internet. But today, in your pocket, as the virtual shadowing crew, all 500 that are here today have heard me say many times, with smartphones and surrounded by computers, you have every fact in the known universe available to you. And therefore, this is lifelong learning like we have never had before. And the thing that is clearly apparent to me is that if one does not know it, look it up, especially if it's going to be part of your part of your ongoing practice. Look it up and become adept at it. And so I feel very, very strongly about that, and that we have definitely overlapping circles in terms of our partnership in healthcare.
Absolutely.
And adding on to Dr. Fowler's comment, I have a question. Can you talk a little bit more on the dynamic you have with the primary care physician in the workplace?
Is that for me?
Yes.
Oh, with who?
The primary care physician.
Oh, my attending or my physician at my office?
Yes.
It's fantastic. So the physician I work with, we work in a private practice in women's health. And so for her, she's been working in women's health for 25 years, and she's been running that practice completely by herself, completely independent, never had mid-levels supporting her. And then so when I was looking around COVID actually, and I was basically, she was actually a family friend. She had even gone to my wedding, and I'm like, have you considered a mid-level, a PA to sort of help you out? And so now, being part of that practice, what primarily happens is, you know, I take a lot of the annuals off of her. She sees more of the complex cases, whereas I see more of the, standard routine GYN cases. We work very hand in hand with our patients. If, I see a new patient, I feel like something's going on, I refer to her. And then we sort of work back and forth. And then if she sees one of my patients, she'll tell me what's going on with that particular one, and then vice versa. So if anything, we very much work as a team. I consider myself her right hand lady. So as far as reviewing labs, I'm always the one to take the load off of her, because at the end of the day, she's the one going into the hospital, delivering the babies. She's the one with the restless nights. So, we make a good team. It's really all a part of the team.
Right. And then I think our last question that we'll do for this portion of questions is, what is the most difficult part of being an OBGYN PA?
I think a hard part about being a women's health PA is sort of being there. I think it's more emotional in that you're there for patients during what is seemingly their more vulnerable points. I actually had a student shadow me today, and I had told her, this situation, this exam we do on these women, they are trusting you with this exam. A lot of these women are not comfortable. They don't know what's going on. They don't even understand their own anatomy. So they are relying on you to convey what their health status is, whether it's their PAP. They are relying on you to educate them on how to prevent, STDs. I came back positive for HSV1. Is this bad? How common is this? So I think the most difficult thing is being able to have the patience and understanding and being able to empathize with them, and that, you really have to take the time out and teach them, because they have no one else to go to other than you. It's just a very, very vulnerable specialty. And in my opinion, if you're not someone who's patient, and if you're not someone who likes to educate very much, I just don't feel like you would be doing the women justice being their provider.
What's the best part of it?
Basic, almost exactly what I said, but providing that education and kind of, like for me, telling them about a PAP and for them to look at me and say, I've had so many exams and no one ever explained that to me. Or, I've had this done, but no one ever told me why it happens, or how that happens. And you just make things sound so easy. And now I get it. And now it encourages them to learn more and be more open about their bodies. So for me, the more I educate and the more I enlighten girls on their own health, to me, that's just the most rewarding thing, because I know that if I wasn't in here in this field, I wouldn't know like 80% of what I know. And that's just, the reality.
There was a famous physicist, Richard Feynman, Nobel laureate, who was at Los Alamos, helped make the bomb. Great teacher. He was very New Jersey. And he used to say, if you really, really want to understand a subject, explain it to an 8-year-old. Because to be able to do that, you've really got to be at brass tacks. But take a half step back from my last question. Let me answer it first. I swear with the passing of time, the thing that's the most important to me is I really enjoy, well, almost all, I really enjoy my patients. I like going and sitting down and talking to them. And I think that's a test of someone who wants to go into healthcare, is that this is a people business. And you've got to legitimately, honestly be interested in the folks you serve. You really do.
That's the thing, you can be great at science and you can be fantastic at anatomy, but you have to remember, there's a person, there's a human to that body. You can't look at the body and just disconnect and say, that's not a person. You have to treat that body as if that was your mom, your dad, your brother, your sister. And so, even with the patients who maybe aren't the nicest or aren't the kindest, you just have to remember at the end of the day, you don't really know what's going on in their life. You don't really know what they go through. And especially, in women's health, you're exposed to a lot of personal stories that make you kind of look back at your life and you're like, mine ain't so bad. So it's just one of those things that you absolutely have to love taking care of people. And by people, not just physical, but emotional, because especially nowadays, they're going hand in hand.
I read something recently and I realized that it's very true, which is as follows. Patients pay a lot of attention to your tone of voice and the inflection of your voice. And so in my world, in the ER, we're the busiest ER in the United States. We're busy. And it's easy to go in the room and say, so what's going on? What's going on? Yeah, well, you got this. You got this. It's this sort of upgoing inflection, as opposed to a diamond-shaped inflection. Well, sir, I see you don't feel very well. I'm going to get you some medicine. I'm going to make you feel better. It goes up like this, and then it ends the sentence coming with a downward inflection. And that patients really respond to that more because you're taking the time to complete a phrase, really showing interest in them as a person.
Absolutely. Yeah. Tone is everything. It's really, it's your body language as well as what you're saying and how you're saying it. That's what, everyone should be mindful of.
Well, keep going.
Okay.
You've been going an hour. Are you doing all right? You doing okay? You want to get some water? You got 500 people hanging on every word out there. Okay, there you go. All right, Kiana, take it away.
Did you say Kiana or Leah? Oh, okay, good.
Oh, sure. And then finally, I think the last question that we will do before we move on to your wonderful presentation is, do a lot of PAs work on the labor and delivery unit, or is that mostly a nurse-dominated floor?
So that I wouldn't be able to provide a great answer for, only because I don't work inpatient, but at one of the hospitals around the area, PAs actually, dominate the labor and delivery floor. As far as what they do, I couldn't tell you just because I don't work in the hospital. I don't see what they do, but, there are definitely positions, especially in our area on labor and delivery, where PAs, dominate the area. It's not just, the nurse practitioners. I find that PAs in women's health are more inpatient based here, and NPs tend to dominate more of the outpatient settings, but that's just from what I've seen.
Okay, well, that is all that I have for this Q&A, so please continue.
All right. So these patient case stories are based off of real patients that I've seen, but of course I've changed age, just basically made it make believe. So we have a 20-year-old, now a G0. So it means that this patient has never been pregnant before. LMP means the first day of the last menstrual period. It's just something we gather on all the patients coming in. So for this particular one, it was November 13 of 20. Her complaint was heavy, irregular periods. That's why she was coming in. Ever since she started her period at the age of 11, they've always been irregular. She can go anywhere from 2 to 5 month intervals of not getting a period. She also admits to a recent increase in facial acne over the past year and states that despite dieting, weight loss has been very difficult for her. Now, she has never actually seen a gynecologist. And so, some people in women's health don't care about like all of their past medical, surgical. I just always ask. I just like to kind of see the bigger picture. So for her, there was nothing really pertinent. She's only 20. She doesn't smoke. She doesn't drink. And she's someone who hasn't been sexually active before. So this is really important when it comes to the physical exam, because a lot of times when a woman has not been sexually active, she will decline the pelvic exam, meaning when we put the speculum in and kind of take a look inside to see what's going on. So just based off her vitals, you can tell that she would be in obese status. She's 226 pounds, 5'3". Blood pressure was decent. So every time I have a patient come in, you do a general appearance. If it's their annual, we'll do breast exam, do an abdominal, pelvic exam. Now the pelvic exam, we're taking a look at the vulva. One thing I love to point out is the vulva is the outside. I feel like people just say vagina and they're referring to the vulva. The vulva is the outside part. The vagina is inside, urethra, cervix, uterus, ovaries. That's what we feel on the manual, or if we can. And then rectal, we'll just see if they have hemorrhoids. Now for this particular patient, she did decline the pelvic exam. And so, I never force it upon any of my patients. I never say they have to do it. I can recommend it, but whether or not they choose to do so is totally up to them. So for her, I just did an abdominal exam, and really I was just seeing if she was tender at all in any of her quadrants, and to make sure that, of course, there was no notable abdominal mass for whatever reason, which everything came back normal. So whenever someone comes in for irregular periods, for some young women, it just could be a normal variant. It doesn't necessarily mean that they have any sort of condition at all. But the things that kind of stood out to me was, her difficulty losing weight, as well as her increase in acne, because what these symptoms are characteristic of having, excessive androgens or higher testosterone levels. So what I want to do is rule out other causes to why she may not be having a period, including, a thyroid condition. And so the labs we ordered are what we call like our PCOS panel or PCO panel, include FSH and LH, which is follicle stimulating hormone and luteinizing hormone. These are hormones that sort of go up and down depending on what parts of the menstrual cycle you're on. We checked her free testosterone level, DHEAs, fasting insulin, TSH, prolactin, and a beta. Now, a beta HCG, for those who don't know, is a marker that tests for pregnancy. And so just because someone hasn't had a period in a while and says that they've never had sex, you really can't trust 100% what someone says. So you always want to run it regardless. And so hers was negative. Basically, everything came out fine. One thing to note is her LH was double her FSH, and her testosterone was elevated, and she had a little bit of insulin resistance. So based off of the lab work, it was suggestive that, she could be someone with some degree of PCOS or polycystic ovarian syndrome. Now, PCOS is actually relatively common. I believe 1 in 7 women have it. But it's also one of the most commonly misdiagnoses. A lot of people tend to overlook it. And so a lot of women don't actually get diagnosed until they're much older. And same thing as far as when they start getting managed for it as well. Now it's, the most important cause of menstrual irregularities and androgen excess. So what you want to look for when we say menstrual irregularity, it means she's having less than 9 periods in a year, or she's going more than 3 months of not getting a period at all. Symptoms of having those androgen excess includes increase in body hair loss, and acne. Now, I sort of religiously follow up to date as far as my way to diagnose someone. And so you can do it through the following criteria listed below. She just has to have 2 of the 3, either not ovulating or ovulating infrequently, let me move this because this is blocking the words. Hyperandrogenism or polycystic ovaries. Now, something to note when you're diagnosing PCOS is if her labs came back negative, hyperandrogenism, you can count it as her hitting the criteria just based off of her symptoms, even though the labs didn't necessarily reflect it. But in her situation, the labs did. And then polycystic ovaries, you do not necessarily have to have cysts on your ovaries to be diagnosed with PCOS. So that's just something to keep in mind. The biggest thing I say to girls when it comes to PCOS is lifestyle modifications are the biggest thing. I know for a lot of patients, it's easy for me to tell them, for me to say, you know, lose weight, but it's obviously a lot harder for them. You know, lifestyle modifications, you're insulin resistant, diet, exercise, it really does make an impact. I've had PCO girls who change their diet, lose weight, and their periods start to regulate a lot better. So this is just something to keep in mind with that. A lot of times what we worry about is these girls are not ovulating, you know, they're not getting periods. So what we want to do is put them on a combined birth control pill to help regulate their periods again, and to start, you know, normalizing their ovulatory cycles. So we would typically, you know, offer birth control pills, and then if needed, get them started on metformin, depending on further workup and if they need it or not. And metformin will also help with losing weight. It's just that a lot of patients don't tolerate it very well. So it's just not my first go-to. I typically like to see how they do with lifestyle modifications first. One thing I always love to say before you give someone a combined birth control pill is to make sure she can take it. A lot of girls don't know what's in birth control pills, which is something I've always stressed on my platform is please know what is in your pill. So for, you know, the quote unquote normal birth control pill, it typically has estrogen and progestin in it. And then there are some pills that are progestin only. They only have one hormone. Now, if a woman has really high blood pressure, if she has known heart disease, if she has a personal history of blood clots, or if she has a close family history of blood clots, you have to question whether or not she can even take a birth control pill. If she's above 35 and a smoker, she cannot be on a combined birth control pill. So you kind of have to go through that criteria as well before you put someone on a birth control pill, because you can increase their risk for getting a blood clot. So for her, what we did is we got her started on a birth control pill. We talked about lifestyle modifications. And then the plan for her was I will see her in 3 months to recheck her blood pressure after starting that pill, because sometimes pills can up your blood pressure. Check on her cycles to see if, you know, they're becoming more regular. And then just make sure she's happy with that pill, because there are hundreds of different birth control pills out there, all with varying doses, varying ways to which you can take them. And sometimes the first pill I give may not be the right one for her. So that's the follow-up with that particular patient. Disclaimer for this one, if you don't like seeing images, there is one image in here. So I don't know why I'd be on a women's health lecture if you weren't necessarily comfortable with it, but just a disclaimer.
Oh, we're ready for it. Let's see it.
Okay, so this was actually when I first started working, and I haven't seen a lot of prolapse in my lifetime, but this one was one of the more exciting cases for me when I first started out. So I had a 75-year-old come in. She was a new patient, and she had called the office because she was showering, and she's like, you know, I just felt a bulge down there, like something came out. It's not there anymore. It went away, but something was there. I feel like it's cancer. You know, can I come in and someone check it? So she came in. Now this patient is a 75-year-old G2, P2, so pregnant twice, 2 live births. Postmenopausal, so you know she's not having any more periods. She came in today, felt like a bulge was falling out of her vagina when she was showering. She states that it only happened once. She never felt it again, but her sister had actually had cervical cancer in the past, and so she was scared that the same thing was happening to her. She said when she felt that bulge, there was no pain at all, but it was there and she just wants to see what that was. Understandably so. So she just had fibromyalgia, the family history. Her sister had cervical cancer. She wasn't a smoker, social drinker. She was a widow. She wasn't currently sexually active, denied any history of having an STD. Her vitals were good, normal BMI. So I listed again what the GYN routine exam is if someone was to come in for their annual. Now for this patient on the right-hand side, we did general appearance, abdominal exam, and so the pelvic exam. So whenever someone comes in with complaint of a bulge and, they are in their 70s, 80s, the first thing you typically think of is a prolapse. Now, what is a prolapse? It's essentially a weakening of muscle. And so something's going to pop out of there. But the question is, what is it that's popping out? And so my dad always used this analogy with his patients that I always use with mine now, because I feel like it's the easiest way for someone not in medicine to sort of understand the vaginal anatomy. And so he would always describe the vagina was a room. And he's like, in the back of that room, you have your cervix. And the ceiling of this room is where your bladder sits. And the floor of this room is where your rectum is. So whenever you have that ceiling drop a little bit, that's what we call a cystocele. Your bladder is dropping into the vagina. If your cervix is getting pushed forward, you have a uterine prolapse. And then if that floor looks like it's getting raised a bit, it's more of a rectocele or rectal prolapse. So when I was looking at her vaginal opening, everything looked fine. I didn't see anything coming out. But what I had realized is as I was talking to her and she would laugh, something would pop right out every time there was pressure or when she would laugh. And so it didn't look like a cervix. When you see a lot of cervixes in your time, you could typically tell what they look like. But what I had to do was confirm where that bulge was coming from. And so that picture right there on the right-hand side is pretty accurate. It's not the best, but it came out a little bit more than that. And so what I over here are the different prolapse types, the bladder, uterine, and rectal. And so for her, when I say manual exam, it's when I put my 2 fingers in the vagina to sort of feel around and see where her anatomy is. And so when I put my fingers in, I was, able to identify where her cervix was. It was back there, wasn't drooping or falling out. So cervix was ruled out. And so what I did was I took that and I pushed it up, and it became very evident that it was actually a cystocele. Her bladder was dropping into the vaginal opening. And, I explained this to her. I explained that it was not cancer. This is something that's really common, over time as we get older, our muscles just tend to weaken, which is why they keep telling us to do Kegels from a very young age, just to kind of keep that infrastructure back up. But for her, she just thought it was cervical cancer. And so treatment options for this is very dependent on what the patient is looking for. Now for her, I offered her a pessary referral to pelvic floor therapy. And then, given her age, I don't know if surgery would have even been the best option for her when weighing out the benefit, risks and the benefits. So if anything, I would have pushed a pessary, which is kind of like a donut support system that a woman will pop in there and it'll hold the floor up. But for her, she didn't want any treatment. She's like, as long as you're telling me this isn't cancer, I am completely good to go. This doesn't even bother me. And some patients will be like that. For me, I'm just like, well, I can't imagine something just popping out and being okay. But if, good for you. If that's what you want, that's what we'll do. So she said she'll just come back in a couple months and have me check on it again to make sure it's not worse. But that was that situation. So, it's 2 patients, complete opposite, sides, different age groups and completely different complaints. And so you sort of, even though it's focused on one area, you see a lot of different cases because every woman's story is a little bit different.
There's a good question. Someone just asked, Could this patient have difficulty urinating because of this?
Very good question. A lot of times people also with prolapse will get, incontinence symptoms. Either, it could be one of two ways. Either she keeps peeing and it's uncontrollable, or she may have difficulty voiding. But in her particular situation, she actually wasn't having any urinary symptoms at all. I've had patients with prolapse come in where me pressing up on it, she would leak all over the place. So it really just depends on the woman.
And then the other question, would that lady be a bit more prone to a urinary tract infection because of the abnormal anatomy now?
In a sense, yes. Just because things are now drooping into, the vaginal area. Now, that's not to say that, technically around the urethra is where you're going to get the most cross contamination, but it can increase the risk for UTIs just because of that weakened pelvic floor.
And finally, does the patient have to be someone who has had children before to have this kind of laxity of the pelvic floor?
Absolutely not. So I think the things that play a big role in it is BMI. People who are heavier set tend to have weaker pelvic floors. And then, of course, history of having, pregnancies. But something that kind of goes in hand with prolapse is just the fact that over time, incontinence is such a big thing from women in their 20s up until they're much older. A lot of women experience some form of urinary incontinence, and these could be your most athletic women. So a lot of these urinary issues, whether it's, weakened pelvic floors or incontinence, the inability to hold in your urine, or maybe when you cough or sneeze, you leak. Women suffer with this who have never had kids. These are active women. These are women who do yoga, they do HIIT classes, they are strength trainers. So, the pelvic floor anatomy is so specific, and a lot of women just aren't accustomed to training that particular area. So even if you've never had a baby, you can definitely have the possibility of experiencing that.
So when you made her laugh, it bulged more. Did you tell her not to tell jokes?
Oh my gosh. I was just like, can you laugh for me again? And she was just like, okay, you have to make it fun, because she was just freaking out. So we were just talking about something random, and I was like, laugh for me, do it again.
Vaginal prolapse, bladder prolapse is when, I do sports medicine quite a bit. And our female patients who are a little bit older, this is a very debilitating part of their life whenever they're athletes. Even things like running, for example, become a problem. So definitely that's another patient population that suffers quite a bit. Our athletes have been high functioning athletes for a very long time, and then prolapse happens, and then the decline is pretty dramatic. So
absolutely.
Impressive.
Yeah. Even incontinence in general, just from what I've seen, is women start to schedule their days and their lives regarding the bathroom breaks. The bathroom really does end up controlling the way they live their life. And when it comes to incontinence, I wish there was more options for them. A lot of women can't tolerate the medication options for the urge incontinence, and pelvic floor therapy works for some. Other people don't want it. Some people don't want surgery. So it's just such a common, prevalent issue that, from a lot of what I'm seeing, women really struggle with it, over time.
It must happen a lot because there are a lot of commercials on TVs for people who need to have underwear that, shall we say, can very quietly, well, need I finish that sentence?
Oh, yeah. Yeah, absolutely. Well, a patient told me I don't know, it's kind of weird. There's like a probe, like a vaginal probe, and they set it up like a video game where it somehow helps with Kegels, but people are really getting creative with the way they're advertising their Kegel.
You've mentioned Kegels twice. You mentioned Kegels twice now. Would you explain that?
So I don't even know if I'm the best person to explain it. So it's basically a pelvic floor exercise. I don't even know like the best descriptive way to describe how to perform a proper Kegel, but
it's trying to hold it real bad.
Exactly. Trying, like you have to pee, but you're trying to hold it, and that motion of doing so is a Kegel.
It's
now
a
the problem is a lot
of the pelvic floor muscles for sure, and it's got to be rhythmic and it's got to be timely, and the release is as important as the actual contraction itself.
Yeah, absolutely. So the pelvic floor therapists know best there.
All right, keep going. This is terrific. You've still
I've
got
never talked
500
so
of your
much in my
closest
life.
friends listening in, Leanna.
Let's see. Oh, and this is just a list of other chief complaints that we see, all varying by parts of the body: urinary, vaginal, breast related, pregnancy related, birth control, STDs. And so it's just a little bit of everything. You know, it's repetitive, but at the same time, no patient is exactly the same. You know, no woman has the same history, has the same background, has the same story. So although the chief complaints to some may seem repetitive, for us, it's every woman is completely different. So it doesn't seem as, repetitive to me at all. It's just, what is this patient's story? And what has she gone through? So in conclusion,
do you find modesty an issue with many patients? I mean, they've got to come take their pants off and let you check their bottom. I mean,
you want to know what's really
patients...
funny is so what will happen is, they're obviously undressed down there, but when I walk in and I notice they're not wearing their gown the right way, like it's open from the back and not open from the front, I'll be like, oh, like, do you mind switching your gown over? And I'll like turn around when like, really, does it even matter? Because I'm looking anyway. But it's like little motions like that where they're like, okay, like give me some privacy. Like they still feel like they have that sort of thing. Some people, especially younger girls who have never had that before, are a lot more nervous. Some people are nervous laughers. Some people just completely freak out and they tense up on you. And what I'll do is really just try to start a conversation. And one thing, I was always taught when it comes to doing like a women's health exam is like when their legs are in the stirrups, always put your hands like on like their knees and go inward and not directly touch smack in the middle. Because number one, they can't see you. And so that's something I'm also very mindful of is communication. This is what I'm doing now. If you get uncomfortable, you tell me. This is where I'm touching now. Because they can't see. Their view is obstructed. They don't know what's going on down there. Or this is the pat brush. You're going to feel it now. So for me, you just can't be like directly go right into it. You have to kind of, if they've never had an exam, desensitize their body to someone touching, and it sort of kind of relaxes the muscles at that point. So by the time you're there, they're not as tense. So there's definitely a technique you have to figure out.
In my world in the ER, I think that we often are insensitive to patients' modesty. Commonly have a guy come in, I got this thing on my penis. And, we're a teaching school, so I'll have like 4 people, 2 med students, a resident, and me, and a nurse, 5 people in the room looking at this guy's penis, And it's
completely different world there.
Some guys really don't care, or actually kind of enjoy it. But a lot of people are pretty embarrassed.
Well, you know what? That's why I find it, I sometimes have like pre-PA shadow me in the office. But at the end of the day, what I tell them is I'm like, I love that you're here and I hope you can see a lot, but I'll always ask the patient if they're even okay with it. Like the patient is going to come first because at the end of the day, this is just a very vulnerable specialty. And the last thing I want is for her to feel like she can't tell me the full story because someone else is in the room, which I have had happen, or that they're just not as comfortable. So you just kind of have to.
Yeah. Leanna, we had a good question a while ago. Jessica asked, do you interact with patients' partners very often?
Well, now with COVID, it's a lot easier to not do so. So, what would typically happen? And this was when I was at my first job and I was working primarily with like Arab Americans, is I would truthfully, so I don't speak Arabic. I understand some, but I just can't relay the information back. So I'll typically have a translator. And so what I would find is specifically with the Arab American community is if we brought the partners back as well, it would be more of him talking and explaining her issue than her explaining her issue, which really I wasn't a big fan of. But now with COVID, they're not allowed back just so long as we have a translator, because then the husbands will say, oh, well, I translate for her. But then we can probably say, well, we have someone. Thank you. Stay in the waiting room. I find that women are a lot more open. My pregnant patients give more opinions, and this is for that particular subset of people. But as far as spouses, with COVID, there's very limited interaction. Very rarely do I end up, talking with them. When COVID wasn't a thing, I had more interaction, but truthfully, I felt like it was more inhibitory when it came to the patient, because I felt like they would do more talking than the patient would.
So take it away.
Okay. Basically, this slide just stresses that, just stay, have persistence, dedication, and hard work. And just because you have a bad GPA or a bad semester doesn't mean you can't move up from there, because what you really want to do is just show growth. And for me, I don't like saying that, having the mindset of there's just this model student, high GPA, high GRE, X amount of patient care hours. A lot of the students with me in my program, we all came from varying backgrounds. We all did different jobs for patient care experience. And we all had very different strengths and weaknesses, which is something, I always loved about the program is, everyone kind of has their own story, and no one really fit that same description. And just, find what you love and continue to do it. For me, the ability to switch specialties whenever I wanted to was a huge reason I went into wanting to be a PA. And I do believe it's a big reason why many PAs love their careers, because that that's what they chose. Because if that's not where they wanted to be, then they would just apply elsewhere and do whatever they wanted to.
This is as opposed to being, say, a nursing practitioner, where you'll have to go do an individual residency, excuse me, in any field that you're working in. It is two different ways to look at it.
Absolutely. And then for me, a lot of people were like, I believe like 2% of 1 to 2 go into women's health as far as PAs. And I think a lot of it is just because it's more nurse practitioner dominant. But for me, if you're passionate about a specialty, don't feel like there aren't enough of, PAs in it, or NPs, or whatever you choose to do. Always reach out and apply. I was sending resumes and emails to places that weren't even asking for jobs. It's just really about building those connections so that maybe one day if they're looking for a PA, they would have my resume and they would contact me. I really recommend looking into residencies. Whenever you decide what specialty you may want to go into. I think it's just a great way to not only further your education, but to make amazing connections with all of the experience that you're going to have. And then for anyone who has more questions, you could always follow me on my account. I basically go through women's health topics every Monday, have Q&As every Wednesday, and we go over different patient case story scenarios on Saturday. And of course, the opinions are my own.
Leon, I suspect that there will be a number of people that would love to exchange an email with you. Is that okay with you?
That would be fine. Yes. Should I just say it out loud? Is that a thing? You know what I would actually prefer? Probably if they messaged me through here.
Absolutely. That is your call. And some of our guests have been fine with that. One of them, God bless him, I know he's answered hundreds of emails, bless his heart. He was also retired, and he has time to do that. So
that's just my one concern. Yeah.
This is terrific. Kiana, do you have some questions for us?
I sure do. The chat has been blowing up with questions, so I'm really excited for you to answer them. So the first one I have is in regards to PCOS treatment options. Do alternative ways, sorry, hold on. Do alternative ways of combined birth control, specifically patches or the ring, apply?
Yes. So, one thing I always say is if someone can't remember to take a pill every day, I always call a NuvaRing like a pill in a ring form. You pop it in, you keep it in there for 3 weeks, take it out week 4, and you get a period. So as long as you know whatever you're taking, what they say, the ring and the patch, is that what they said?
Yes.
Now, the thing with the patch is if you are someone with a higher BMI, it doesn't work as well. So that's the only disclaimer regarding the patch is the absorption is just not going to be as strong for someone who has a higher BMI than someone within like the normal range. And I know with a lot of girls who are PCOS, they struggle a lot with the weight gain. So that may not be my recommendation as their first go-to.
Okay, cool. And how has the OB/GYN profession changed since you have begun working? And are there any things that you would change?
How has it changed?
Mm-hmm.
More ultrasound, different kinds of imaging techniques.
Oh, well, we just got this really cool colposcopy that basically tells you where to biopsy. It's crazy what they're doing with technology nowadays. Because, colposcopies can be very subjective in a way where you're putting, the vinegar on the cervix, and with your eye, you're trying to visualize where the most acetyl white changes are, and that's where you biopsy. And now, we have this colposcope that sprays the acetic acid on for you and will highlight and show you on a computer where it's seeing most of the acetyl white changes.
Mm-hmm.
So I think technology is definitely getting significantly better, almost in a scary way where it's just making jobs a little bit too easy.
Well, that's exactly right. Though it may give our brains more time to think about other things. It's not artificial intelligence, it's augmented intelligence, AI, and it's coming in a tidal wave without any question. I was reading last week, and I think it was New England Journal, it was talking about the fact that doctors by and large stink at doing rare diagnoses because they never see them. But I think that augmented intelligence is going to really be quite helpful for us going forward, so that folks with white hair like Dr. Salazar doesn't have to stretch his memory so much, but actually will be able to recall things that with computer assistance.
For sure. And, the EMR systems they're using now, just are becoming bigger, better connected, across the nation, rather than like the paper charts, of course. And so things are becoming easier, but it's just a matter of not relying solely on the technology and still remembering the essentials of medicine.
I would throw in there that reproductive health is in terms of folks who can't conceive. That technology has changed quite a bit and has brought up a lot of interesting clinical, ethical, and moral questions as well. And that's also been an interesting aspect in my humble opinion.
Yeah, I completely agree.
And then another question is, for women who mention they are sexual assault survivors or generally particularly uncomfortable, how do you change your approach to care?
So a lot of it for me is, and I've had patients who were survivors, a lot of it is communication and patience, especially communication. Every move, every touch it matters with them. So she's kind of in control of the exam versus me being in control of the exam necessarily. So I think, with all patients, my communication is always there and the permission is always asked. But with them in particular, you just have to be more sensitive, more patient, especially more patient and just slower. and then just describing everything you're doing and having them control the exam and making them feel in control versus them feeling like they can't talk to you and they're just going to let you do what you have to do and then call it a day.
Leanna, specifically, do you do sexual assault exams? We have a specific team in our hospital that does those for us.
We actually don't. We do not. If anything, if we suspect anything, we'll actually have them go to the hospital nearby.
Do you deal with transgender patients at all?
You know, I think maybe one or two of them. And for me, I feel like there's been just a better understanding as far as like the LGBTQ community, better understanding of pronoun use. So we try to accommodate as much as we can. And so whatever pronouns, whatever names, he or she may want to go by, that's totally up to them. I've had patients who not say anything, and then I'll ask if I suspect that maybe the pronoun I use is maybe not the one they would have preferred. And so I kind of like to keep that conversation open. And, I've heard from patients that some clinics, they would just refuse to see them just because of the name change and just the way they identified. So I think over time, there will be more of an understanding and acceptance of that. I just think it really depends on how quote unquote old school the provider is.
Right. And you said just how the importance of communicating with those who were sexually assaulted and just the tone. How does your approach change with those with eating disorders?
So I can't say I personally have had experience with those with eating disorders. I personally have not, and not to my knowledge. So I can't really speak firsthand on that. But at the end of the day, whether someone has an eating disorder, whether someone has a psychological disorder, regardless, in my opinion, you should be giving them the same quality of care that you would anyone else. Of course, with more patience and understanding, but really, in a sense, you should be providing that for all people because there are things patients won't tell you. I could see someone and not know they have an eating disorder, and then they be going through it. And so I'm not going to kind of provide care and live by, well, if they don't tell me they don't have it, I'm just going to treat anyone how I would want to be treated regardless of the situation.
Exactly. Yeah. And then just a few more questions. How do you deal with the influences of politics on women's health?
They say politics? Is that what they
Yeah,
said?
yeah. The influence of politics on women's health. Do you, in this era, this woke era where times are changing and our cultural sensitivity is having to broaden like never before, what do you find in people, especially younger people, even what's beyond millennials, iGen or whatever it is? And
I cannot keep up. So I guess I'm having a hard time understanding the question.
Have you found that there is a changing sensitivity among the women that you take care of? Let's say women you would take care of that are my age, old, versus young folks coming out of high school that, they're there with smartphone in hand, and that you're having to do different kinds of communication, if you will, for different generations.
It's interesting. It's kind of why I even created this Instagram thing, is I'm like, all people are on nowadays, all of the younger generation are learning their knowledge through social media. I have patients coming to me and they're like, I have PCOS and I follow this PCOS influencer and she doesn't use metformin. So what are your thoughts? She uses this herbal, whatever. And, I'm over here sticking to up to date. Like I'm kind of going based off what I know and what the research says. But when it comes to the younger generation, every opinion they have everything they know is from someone they follow, a TikTok they've seen. I don't want an IUD because I've seen a video and it just doesn't look great. So with the younger generation, they're exposed to so many different personal experiences that they form their opinion based off of that, versus I'm here for an IUD consult. Can you tell me what it's like? Can you tell me what the process is and what the side effects are? No, that doesn't matter with them. It's more of, well, I saw how so-and-so had her insertion and this is the side effects she experienced, and I don't want that for me.
Right.
Versus more of the, older generations where they actually, I find easygoing. Can you just explain why this is happening to me? And then you explain it, and then they appreciate your knowledge. They don't really have like an opinion already set as much as the younger generation does.
Following on just quickly, this is also the era where patients now have direct access to their own medical records,
Oh, yes.
my chart or other things. And folks, all of you out there, the 400 plus that are out there, you got to be careful what you put in a chart, folks. You put on there, you make a comment, a guy comes in weighing about 480 pounds, and you put a comment on the chart. This morbidly obese patient, well, he can see that.
Yep.
And you got to be careful, because you'll be surprised what it is will be found out about what you write and so forth. So.
Exactly. And something I always tell people who want to be PAs or doctors is, when you document everything you said, everything that happened, because if God forbid something happens, they are going to look at your notes religiously. And, you can say you did one thing, but if it's not in the note, it's as if you never even did it. And we use Epic, we use MyChart. And, one thing I love about it is, the stickies, the yellow stickies where you can put something personal about that patient that helps you kind of remember who that is. And you can always ask them about it. But the downside of it, of course, is they can see everything you write. So I have a generic template and I just, avoid as much adjectives as I could.
Well, I had a patient the other day, came in with a bad headache, a middle-aged woman. And she wanted a second opinion here in our ER about her headaches. And I said, well, yeah, and she wanted another scan. I said, well, do you have the original scan? And lo and behold, she pops out her smartphone, pulls up my chart, goes to the other hospital and pulls up the MRI report of her brain.
Yeah.
And I said, holy cow, I can't do that on Epic here at this hospital. And in fact, the MRI was normal. I said, you've had the test. You don't need another test.
Oh, but then they'll also call and say, you diagnosed me as this and this. That's not what I have. Or, the diagnosis codes you use, they're watching it and making sure that's exactly, what you told them their diagnosis was. I've had patients call regarding diagnosis codes we've used, and they're just like, what does that mean? Why are you saying that's what I have? So patients can see everything.
Absolutely. Kiana, let's do one more, and then we're going to let this sweet lady have the rest of her evening.
Finally, what's something you wish you had known before becoming an OB/GYN PA, before pursuing that path? And what advice do you have for pre-PAs?
I feel like something I would have told myself when I first started is, it's okay to feel like you know nothing, because when looking at the picture of things, you've had 4 weeks of women's health experience. So it's okay. A lot of your confidence builds while you're working, and, you really learn on the job. You, of course, always have to be studying. I learn every single day. Truthfully, one of the reasons I even keep up with the page is because it forces me to keep up with up-to-date knowledge, forces me to keep reading back to make sure there's not any new medications out there, any new better treatment options. You're every day going to be learning and keep learning. And when it comes to advice for pre-PAs, it's, do what you love, and regardless of what your background is, regardless of whether you think your grades are good enough or not, just move forward and just do better. And then, you'll get there with time and perseverance.
Liana, what a wonderful talk. Thank you so much. Let's have everybody put a thank you, Liana, into chat for you right now. And everybody pop that in there right now, would you? And so she can see just how very much you appreciate you taking the time with your sweet demeanor, your amazing skill, your interesting background. You made a C or a D and you didn't give up, and you turned around and you turned it all into the most positive possible outcome. We want to thank you all for being here, everybody. Virtual shadowing means a lot to the virtual shadowing team, Dr. Salazar and me and Dr. Reno and all of the team. We're so very grateful that you keep coming back. The 250,000 views that we've had of our programs and so on mean that we've touched a lot of hearts, a lot of minds out there, and we hope that we've shared with you something that'll give you thoughts as you go forward. Do I have a career in healthcare ahead of me where I'm going to go get involved in the lives of others to bring an applied science to better the human condition? That is the question that you have to answer for yourself. And we can't do that. It'll be you. So anyway, we'll be here next week. And let's see, Kiana, don't you have some announcements for us?
I sure do. Liana, if you don't mind, could you go to the next slide, please?
Oh, give me 1 second.
One more. Perfect. Okay, for all of you guys still here, this is the QR code for the quiz for the 50 session. It will be due next week at 6:59 p.m. Central Standard Time. And an announcement is that we will be having a bonus session next week, May 13th, with UT Southwestern med school students, and we will send out a survey in our emails to get an idea of questions for med school admissions. Please note that this is not for virtual shadowing credit, but we'd love to see you. And that is the end of our session. Dr. Fowler, want to close us out?
So thanks so much for coming. Gil, any quick words about the virtual clinical observation program?
Hey guys, we have our session number 4 is going to be called Severe Disease and Injury. That's going to be on Thursday, the 6th at 7 p.m. Registration is required. So www.vcop.ws, or you can go to my Instagram. I'll put it in the chat. So got to register ASAP. Thank you.
Thank you so much, Gil. Y'all really need to tune into that program. It is second to none, and I think it'll really continue to expand on many of the concepts we've begun the covering of here at Virtual Shadowing. So we're wrapping up another evening. Liana, again, thank you so much for your kindness and your sweet demeanor and just your amazing skill. And on behalf of the whole Virtual Shadowing team, we want to say thank you so much for coming. We will see you next week.